Okay, so with ICU environment, this is some of the things that you would expect to have in the ICU. So the general idea is these people are going to be unstable, hemodynamically unstable. They're going to have issues with their ABCs. So these are some examples of some things you will see in the ICU. Hopefully, during your rotation, you'll get to actually go there to see what's going on. If you have any specific ICU questions, I would recommend messaging Kaylin because she works in the ICU, so she will have firsthand experience. Okay. So yeah, some of the examples you'll see, septic shock, people that are not responding to typical protocol, they're having severe vasodilation, low blood pressure, could be edematous from the inflammation. They're not going to be reactive to fluid boluses. They're going to require to be on vasopressors that need to be titrated. These are the critical care drugs. Some of them include norepinephrine, vasopressin, epinephrine, dopamine if it gets really bad, and things like that. They'll be sedated some of the time, depending on the floor, maybe all of the time. So they'll have things like propofol drip, fentanyl drip, Precedex, all of this kind of stuff here. So another thing that people will be there for is respiratory failure. So it's another ABCs related issue of instability. This person might be ventilated, so they'll have mechanical ventilation, the tube breathing for them, and part of your job will be to keep them at a certain sedation level so that they're not fighting the vent, making sure that they're stable, and eventually, hopefully, being able to wean them off, doing ventilation trials to see how they tolerate being off the vent or being on lower settings, etc. Depending on their condition, they might be getting things such as nebulizer treatment, steroid treatment. People that are in severe DKA or HHNS, they're having still considered an ABC issue because they're going to be very highly dehydrated. Electrolyte imbalances. This person needs to be on an insulin drip. They're going to have a severe acid-base balance imbalance. People coming after a very extensive surgery, such as a Whipple or a cabbage, would be in the ICU for monitoring, and then for just being the highest level of care they could get in case of a consequence of their procedure. People that go to burns will hopefully go to a specific like burn unit that specializes in it, but people that have burns are going to have massive shifts in the fluid, which is going to lead to shock. They're going to have shifts in electrolytes, which can lead to heart issues. Their skin is out into the open, so they have a risk of infection leading to sepsis. People with severe trauma, they can go to a trauma ICU. People that have been in motor vehicle accidents, suffering from spinal cord injuries, internal bleeding, hemorrhaging, subarachnoid hemorrhaging, epidural um, hemorrhaging, all that kind of stuff. And then kind of we talked about severe. Hello, can you hear me? Sorry, I disconnected. Can you guys hear me?
Yes, now we can.
Okay. Where did I leave off from your guys' perspective?
I would have to look at that PowerPoint.
Fair.
Yeah, it was right. Yeah, right about there. The
Okay,
tr-
perfect.
the Cam.
Okay. So did you guys go over this? I know when I was working in the Sims lab, I mentioned this during one of the simulations, but I don't know if this is something that they kind of mentioned again for during lecture or not. Do you guys know about the think acronym?
just read about it, but I don't remember him going over it.
Okay, this was more like a Miss Brooks thing. She likes this one. I do think it's pretty helpful though. So what this is change in camp score. So that would be like kind of like the confusion scale. So this is if somebody is acutely altered, these are some things that you're gonna want to think about because it kind of helps to provide a little bit more context, like what could be going on. So it kind of shifts your priority of some of the things that you should be assessing or some of the things that could be happening. So the T here would stand for toxicity. So that can include things such as overdosing on medications. Maybe they're too sedated from opioids. I've heard some stories from one of the previous instructors. They had a patient that was a like a drug addict, and I don't know if they had a visitor or they managed to sneak it in through their belongings, but they basically picked up a flush, an IB flush that was in the trash can. So the nurse did like a flush, and then they went dug into the trash can, took that syringe for the IB flush, and they managed to fill it up with some sort of drug, and then they were able to directly get that into their IV to get high. I think they died from overdose doing that. Digoxin toxicity. Um, and the H here would stand for hypoxia, so lack of oxygen. So if somebody is acutely altered, you do want to think possible ABCs issue. So you want to take their vital signs in general, just get a vital sign, see what's going on. Are they showing signs of like a stroke or something, or are they showing um, lack of oxygen or anything else? I is going to be for infection. So somebody with a UTI can become altered, especially when they're older. The N would be is kind of like a little cop out just to make the acronym fit, but it's like non-pharmacological reasons. So this would include things such as dehydration, low blood sugar. So when somebody has a potential risk of stroke, they're going to want to do a blood sugar to see that if their altered is actually being caused due to low blood sugar. Could be because of a thyroid storm. The K would be K for potassium, but it's kind of related to like other electrolytes as well. So in particular, somebody being altered, electrolyte, someone being altered or looking altered could be due to like a low sodium level below 125. Um, that patient will look altered. They'll have a risk of higher risk of seizures happening. So these are things to kind of think about. So if someone's altered, take their vital signs, make sure they're not hypoxic, take their blood sugar, make sure that they don't need to get anything for that. Maybe it's their labs, maybe it's an infection happening, or maybe if they're on medication like digoxin, or if they're on sedation or something, they're not being overly sedated. So things like that is just kind of like a nice little acronym. So central line, this is just going to be a quick review. You are going to be tested on central line. So, and you guys were doing your central line dressing change recently, but then like they'll pass within this week or last week. Um, oh, you guys did it on 2:30 actually. Okay. Well, but so what are some reasons that you guys can remember for why someone could get a central line?
Long-term antibiotics,
Yeah, so
blood dr-
long-term antibiotics,
blood draws,
sure, blood draws, long-term antibiotics slash just IV therapy of any kind.
chemo drugs, I believe,
Yeah,
right?
so that would be another thing. So
Uh,
just long-term IV. So let's antibiotics,
uh,
chemotherapy for sure. Chemotherapy. What about somebody that has been
Um,
NPO for a week, can't get anything
oh,
down,
TP.
TPN, because the TPN is too, osmolarity of it is too much for a peripheral line, so they need to have a central line for that. Sometimes they just put one in because they're a difficult stick, so they might get the pick team to do that. Another reason could be someone getting vesicants, so things that could be uh can extravasate really easily through the peripheral line. So pressors, for example, certain antibiotics. Does it still happen? Yes, but it's going to be a lot safer to do it through a central line. So for review, I'll have a picture. Kind of, kind of does that. But let me see. What are some things that you guys remember from the non-tunneled? So let me see if I can get it without having the text spoil it. So the non-tunneled is going to be the one that happens in that upper chest area. You guys remember what that one specifically used for? Like what is the indications for that? What are some of the risks for it? Benefits versus risks for it?
For the non-tunneled, you said?
Yeah, for the non-tunneled.
I thought me saying out loud would give me a clue to myself, but it didn't.
I think it has to be where the position of it is, right? Because you can't push it in because that can cause dysrhythmias or something.
I mean, at the end of the
Or am
day,
I completely
they're all
off?
kind of going to the same spot here of the heart. It is the position of it does, and like the way it's placed does definitely make a difference in terms of use case scenario and risk factors for it. What comes to mind? I'll tell you that it's used for short term. So it's a short term type of central line, and it's used for emergencies. So if this is something that you can kind of just, and by you I mean not you actually. The person placing this will be the doctor, or somebody that's specifically trained to do a central line insertion. So this is used for an emergency. The reason why is because there's no need for surgery to place or remove. But because it is just kind of like stick it and go emergency time, what do you think that puts you at higher risk for?
Infection.
Infection, yeah. So this one's gonna have a higher risk for infection compared to the other ones. Central lines in general, of course, have that risk for infection, some more than others, but that's the CLAPSI. This one is also going to have a risk for something. So after you get the central line placed, there needs to be something done afterwards for safety reasons. Do you guys remember what that
And
is?
you're at risk for clot.
Is it for placement?
For placement and then another thing. So you need a chest X-ray. So it helps you determine placement and then what else could happen if you're just kind of sticking a line in there haphazardly in an emergency. So whoop, heart's right here. Whoop. What could you puncture accidentally?
A trach? No, it's not trachea, right?
Along the same line, the lungs. So
Oh shit.
pneumothorax. So this
Yeah.
person assess for pneumothorax, and the shorthand for that is PTX. So this is a risk for almost all of your central lines is pneumothorax. So in general, you want to do a chest X-ray after because one, it helps you with placement. Two, it um, lets you see if there was the presence of pneumothorax, and there's signs and symptoms of it as well, but it's just kind of part of routine. You don't want it to accidentally happen and then, not catch it, plus also the placement. So it's kind of like a two for one there. So that's the main idea. Non-tunnel, it's for emergencies. You can just kind of stick it and go. But in that case, you're also having a higher risk of infection, a higher risk for pneumothorax. The next one would be a tunneled. So you can kind of see here, you can kind of see it very lightly here that there is this little, like this little circle here. This little circle here is kind of like the hub. So that's the insertion site. So non-tunneled, it's insertion site here, makes it to the intended location, and then the hub and everything else, the line sticking out, are just directly outside of that insertion site. Here, the insertion site is in the same spot, but you have this extended line that is going to be tunneled underneath some subcutaneous tissue and then make an exit a little bit further down the line. So compared to that, um, here's the explanation there. What are the benefits that you guys can remember for this type of line as opposed to a non-tunneled? So, so in terms of tunnel, this one needs surgery to place and to remove. So talk to me about how is this one more longer term than the non-tunneled, or is it meant for longer term? Is it meant for short term? What is the risk of infection compared to non-tunneled? That's what I'm looking for here. Yeah, so it's going to be a longer term thing. It's surgically placed. It's more methodically placed. So it's going to be a longer term thing. It's not going to be there for as an emergency thing because you have to surgically put it in. There's also going to be a less risk of infection. So the idea behind that, um, the tunneling is that you have a longer line. So as opposed to here with the non-tunneled, any bacteria or pathogens that make it through the line or make it through the site has a shorter travel distance to make it to the heart. While here, there's this considerably longer distance that it would need to travel. I would think of it kind of like the idea behind how uh, females have a higher risk for UTI than males. Their urethra compared to their bladder is just considerably shorter than a man, which has a lot of, depending on the person, has a lot of buffer in between their, their entrance site versus their bladder. So that gives the man a lower risk of UTI development just from the length. Same idea. So you have an increased length, and therefore the chances of the infection is much lower due to the. Does that make sense? Okay, cool. And then same idea though with the tunnel versus non-tunneled. You're still gonna need to do a chest X-ray, okay? Same idea. It's still in the exact same insertion site, but it's gonna be, I would say it's gonna be less likely because it's surgically placed, more methodically placed versus emergency placed. But you're still needed just for positioning. Still same thing for positioning and pneumothorax, okay? So this is what I'm gonna keep highlighting because we're gonna see a question that is going to be relating to that, where that knowledge is gonna be relevant. Okay. Next is a PICC line. A PICC line stands for peripherally inserted central catheter. So this is a central line, but is inserted peripherally. So let me see if I can get a picture. PICC. So here you'll see that it's going to be inserted, like for example, like in the AC, um, but it's going to travel all the way, still make it to that same spot in the heart. So the difference here is just the length is going to be the difference. So this PICC line is going to be there for short to intermediate therapy. Sometimes people are discharged with a PICC line so that they can do their antibiotics at home. Um, so with this, there's a few different caveats that you want to consider. So what are some things? Have you guys ever had a patient with a PICC line during clinicals? Yeah?
Yes.
Okay. What is something that you noticed when you were doing your assessment or doing your vital signs that you needed to kind of keep notice of with someone that has a PICC line? Let's say they have a PICC line on their right side.
I noticed that we didn't do like vitals on that side.
Yeah, so you're not supposed to do vitals on that sign. The reason for that is because that could cause cause an issue with the PICC line. It could cause a risk for clots being dislodged or clots kind of making its way through. And that's going to be one of the cause for concerns with the PICC line in general. Um, so something that you're supposed to do with the PICC line is going to be measuring the arm. So we'll need to measure the arm to assess for clots. Putting pressure there with a blood pressure machine could lead to the formation of clots from the pressure and then things kind of being held back, um, building up a clot that way, and then it being released from the cuff being releasing the pressure. So it um, increases the risk of clots, maybe even could increase the risk of changing the positioning of the PICC line. But the idea is that if you have a PICC line, there should be a sign on the wall that says no blood pressure on that arm. So you're not doing blood pressure on the arm. These were clots. Let's see. Let me do it like this. And then the patient should be mindful of their movement of their arms and stuff. Let's do that. So patients should not have their blood pressure taken on the arm that their PICC line is placed. Should be mindful of arm movement and exercise lifting. So try not to have their arm go above their shoulder. Again, that could disposition the whole thing. Okay, so that's going to be an important thing that you could be tested on for the PICC line. Um, for your central line insertion, one of the things that you're doing is that you're kind of keeping track of where the same with your NG tube, keeping track of that external length. So you're measuring the external length, keeping track of it, documenting the external length. And then when it comes to this, you're checking how much has been pulled out or pushed in just from movement or anything that might cause that to happen. If the catheter has been if the catheter has been pushed out or pulled out, are you allowed to push it in?
No.
No. Okay. If the catheter has been pushed in, are you allowed to pull it out? Yes. So pull out game strong. That's how I remember it. Uh, so that's we can keep that one in mind for what we're allowed to do and what we're not allowed to do. But yeah, you want to keep track of that external line measure. You could let the doctor know if it's been pushed in because sorry, if it's been pulled out because you can't push it back in due to infection risk. Okay, that's important. Boop, boop, boop. And then are you going to want to do a chest x-ray after this one? I don't know if you guys have already answered or not. I can't tell. So chest x-ray, yes, no for the PICC line. Yeah, so same thing, placement. The chances of a pneumothorax is basically zero because it's peripherally inserted. So the lung is nowhere near this insertion site. So it's virtually a 0% risk of pneumothorax, but you still want to do it to confirm placement. So that's the good thing is that you could just remember you need to do a chest x-ray after a central line. And that will cover you for all of them. But regardless, that's still the case, okay? So the main things with the PICC line that you're going to want to think about is going to be measuring the arm due to risk for clotting. So you would get like the little paper rulers and just kind of measure the circumference of the arm and keep track of that. Okay. The implanted one, this one I'll just kind of talk about. This is like the port. This one is going to be for long term for multiple years, used for a lot of times chemotherapy, and you're going to need a special needle to access it. So you're able to put that in to access it, and then that access lasts for a certain amount of time. You're gonna need to flush it with heparin. Less focus on this one for the test and stuff. It's gonna be more about kind of the understanding of how a PICC line needs clot, measuring for clot, assessing for clots, measuring, knowing whether you're allowed to pull in or push in. The external length, knowing about that you need a chest X-ray due to pneumothorax risk. That's going to be your main concern for the central line, and knowing some of the reasons for why they would be used. So what are some complications that can occur? We did talk about a few. We talked about pneumothorax. What else can we talked about eclampsia, the infection risk. What else can you guys think about? I guess we also talked about thromboembolism when it comes to the PICC line. Anything else that comes to mind when it comes to central line insertion that could be a possible complication? So we talked about complications of just complications of insertion, complications of having it placed at all. Is there any complications with taking it out? I guess technically with putting it in too, but complications when taking it out. There's one major one that comes to mind. Sure, sure, bleeding for sure, because it could happen or will happen to some degree. But because it is a big vein. I'm thinking of something else that taking it out exposes the thing to. So one of the things you're supposed to do when you're removing a central line is that you're supposed to have them bear down, hold their breath. Yes, air embolism. So that's the reason why you're supposed to have them bear down, hold their breath, um, because you don't want it to have air come in and cause an air embolism. So for now, let's talk about some of the signs and symptoms of all of these kind of things. So what are some signs and symptoms that you guys can think about that would relate to a pneumothorax? Just so if you have a question that doesn't tell you this patient's having a pneumothorax, they just tell you this is what they're experiencing uh, related to a central line, although it'd be kind of obvious, but just so that they ask you a question, maybe it's a multiple choice question, like what are some signs and symptoms of a pneumothorax? How would you answer that?
Chest pain?
Yes. So this person can have chest pain for sure. You can even say it's pleuritic, so
Yeah.
chest pain while breathing. Go ahead.
Oh, I lost my train of thought. Oh, but the chest pain will fall up under like if it's deviated to the left or right.
Yeah, it can have it will have an uneven chest rise
Oh, okay.
because if you have like a pneumothorax on your right side versus your left side, um, uneven chest rise. The pressures are different. The pressures are completely different. So maybe we can take a look at a pneumothorax. And when you have your pneumothorax like this, right, you're gonna have uneven chest rise because this lung can obviously inflate and deflate at different levels than this collapsed lung can. So yeah, uneven chest rise. What else can kind of come to mind? So if somebody is having difficulty breathing, what do you think
Oh,
their
shortness.
vitals, shortness of breath slash
Maybe
dyspnea,
tachy.
they're gonna be tacky, yes. I'm gonna put hypoxic because I know it exists somewhere in there in your head. It's just we're thinking of all the weird stuff for now. What do you think their lung sounds will sound like? Diminished on the one side, yeah, exactly. So this is where you'll hear that diminished lung sound. So hopefully you got a baseline as well, so you can make that determination of it sounds less loud than before. And then what are some of your things that you can expect this person, like if this person does have a pneumothorax, what are you doing? What are you calling a rapid? Sure. But what else are you doing while that rapid's getting there? Giving them O2, yeah. And then you can expect this person to have a chest tube go on. And then you'll be managing probably depending on your floor, you'll be transferring them actually. But that's the idea. All right, cool. Um, Air embolism's pretty similar, so we'll actually talk about that one next. This one is going to have a lot of the same exact stuff. It's going to have tachypnea, dyspnea, shortness of breath, tachycardia, chest pain. The thing that you'll see is the chest rise is not going to be the same way. Um, it is very similar. It's going to be context based, but also, you know, it it's not going to have that same type of chest rise. It's not going to have the the diminished lung sounds as much on that front. So they are similar though, but this is what you want to prevent when you're removing a central line. So when you're removing a central line, you have to tell them bear down, hold your breath, try not to talk or laugh. For the thromboembolism, we've already discussed some of that. So you want to measure the arm to assess, flush frequently. For the CLAPSY, some things that did he ever mention like the an acronym for it, like the SAVE acronym? You probably wanna learn the SAVE acronym for a multiple choice. I mean, for a possible question. Who can remember the SAVE acronym or any part of it? Some things that kind of go with it. They have an infection, less than 24 hours after inserting a central line. It's not likely to be related. That's the general case. So I'll help you a little bit on here. So you might not have mentioned that. I don't know if you took that part out, but I probably have expect some sort of question similar. So the S one is definitely a stretch, but hand hygiene, aseptic technique, vigorous friction to the hubs, and ensuring patency. So I expect maybe some of this to come up on like a multiple choice or something like that. Something else that could happen is like arrhythmias because you are putting a line into the heart, so the heart might not take that very well. So then you just respond based on the algorithm. Let the doctor know. Some nursing considerations, we basically already talked about all that stuff here. Confirm placement, aseptic technique, and keep note of that. It's aseptic technique, um, not clean technique, okay? Clean technique is referring to standard precautions. Okay, so you're not doing this with clean gloves, you're doing this with sterile gloves. So don't put the answer that says clean gloves because that's clean gloves is referring to standard precautions, the regular gloves. For your dressing changes, how often is that being done?
Usually every 7 day or as ordered.
Yeah, so every 7 days per policy as needed. If it's 30, you can do it. Um, the dressing changes with a transparent semi-permeable membrane. That's what it's called. So if that is a relevant thing that's relevant to your quiz, then you heard it. You heard it already. Transparent semi-permeable membrane. Okay. But that's the main gist of that. Any questions on central lines? And then we'll move on to the hemodynamics part of it. Okay. So the hemodynamics, here's an example of a monitor. Um, you'll have your EKG, you'll have your O2 sats, your arterial blood pressure, your MAP, your pulmonary pressure is your central venous pressure, your wedge pressure, all that kind of stuff is things that an ICU nurse will use to make assessments, terminations of things, get an idea of what's going on. Did you guys ever discuss the Allen test or get to do the Allen test?
I don't think so, no.
No? Okay. So
Isn't that for blood flow? Just for
yeah,
blood?
basically, yeah.
Okay.
So the idea is yeah, the Allen test is done before placement of an arterial line. So that would be a line that's going to go through your artery. That very typically it's the radial artery, so that's the one where you're feeling the pulse for. The idea of the Allen test is to determine, so you can see here you have an artery here and you have an artery here. So this is your radial artery. This is your ulnar artery. The idea is that you're gonna be shutting off the circulation with applying pressure to both until your hand gets white colored, very pale looking, and then you're going to be letting go of the pressure on the ulnar artery, so letting go of the pressure here, so that you're only applying pressure to the radial artery. And the idea is that if your hand uh, gets all its color, gets its color back, rewarms up, that it's showing that you have enough proper circulation to have a line be placed there and essentially be partially interrupting the flow of blood. So it's basically making sure that they're putting this A line in and it's not gonna take away your hand circulation. So to do that, block off both of those arteries, pump their fist, hand becomes pale, let go of the ulnar and see how well that hand can tolerate having the radial artery be obstructed. Okay. What is the purpose of an arterial line? What is it used for?
Continuous blood pressure monitoring, right? And to
Hmm.
do blood draws for ABGs.
Yes. So continuous way to monitor blood pressure slash MAP and get arterial blood gases. Perfect. So what is the formula? Because this isn't, I mean, some of them might, I guess, just automatically calculate it, but you will on your test have to calculate it yourself.
The formula for MAP, you're saying?
Uh-huh. Yes.
Yeah. Oh, go ahead. I thought Hung was saying something, no?
Oh no, I was on mute, but go ahead,
Oh,
Marlon.
it's the diastolic times 2,
Hmm.
then you add the systolic and you divide by 3, right?
Yes, correct. So you're gonna 100% want to know that. Okay. You're gonna have, will probably have questions where they will give you the blood pressures, but you're actually supposed to calculate the MAP, your map, and you're gonna want to know that because they're not gonna provide you the formula. So you're gonna want to have that memorized. And approximately this range is good perfusion. Typically, they want 65 or higher. So in the ICU, they'll have like map goals for your vasopressors. And very typically, it will be 65 plus, depending on the person. It could be a different number, like 55 plus, 60 plus, but 65 plus will be the typical map goal. But yeah, this is a way to continuously be able to monitor the blood pressure and things like that. So you're definitely going to want to know this formula right here. The benefits, like we mentioned, continuous monitoring, so we can titrate vasopressors in real time. Some additional considerations here is that because this is placed in an arterial, if it gets dislodged or gets the placement is off, that will throw off the numbers, and it will also, if it gets dislodged somehow, the risk of bleeding is much higher with an arterial. You're going to bleed out pretty fast. It's going to sprinkle everywhere. Well, not sprinkle, but it's gonna like a big hose. Okay, so you're gonna want to splint the wrist to make sure that there's less movement that's gonna happen that could move that thing around. If there is a change in position, you're gonna readjust, recalibrate. So one of the calibrations is done. Uh, Here's like an example of what that would look like. So there's a pressure bag. You don't have to know the specifics of it, but it's set up with a sort of pressure bag, a stopcock here, and this little thing slides up and down on the IV pole, and it needs to be calibrated to their, it's called the phlebostatic axis. And so that is going to be, let me get the picture of it. Phlebostatic axis location, kind of like midline of their chest. So Kalen's saying fourth intercostal midclavicular, which is the very specific spot. We did not get asked that specific on our test, but if he changed it, it could be. So I just want you to keep that in mind. So here's the picture. So fourth intercostal space in the mid axillary midclavicular line. So if you get asked that on, it could be an NCLEX question, possibly, or possibly not, because I guess critical care is not even in the on the NCLEX, to be honest. That being said, if you are interested in the ICU, um, from Kaylin's experience, she has noticed that having gone to Cerritos made a big difference for her because a lot of the new grads that started with her didn't know a lot of the stuff that they're actually teaching here because the critical care courses have actually been kind of phased out because it's not being taught on the NCLEX, so they're not teaching critical care. It's not required for the curriculums anymore. So people aren't being taught the critical care stuff. So people that want to join the ICU are gonna have to learn from zero what you'll be getting an idea of here. And then depending on your clinical site, you might actually get to do, well, I guess you don't do preceptorships anymore. So I'm not sure how that's going to go for you guys, but you might have a bit more experience actually getting to do a rotation in the ICU. So you'll get to see certain things, do certain things. Kaylin was very lucky. She got to do a preceptorship, like 5 shifts at an actual in the ICU, where she was doing a lot of stuff that a lot of other people in nursing school don't get to do. So if you get to, so that's um, so that's something that if you do get to experience that and you're interested in the ICU, that's good. That's a good thing here. So something though, that you're
I have
gonna
a really
want.
quick
Oh yeah,
question.
go for it. Go for it.
Sorry, Diego. I think it's a dumb question, but regarding the map, in the event if we happen to have it in decimal point, do we round it to the whole number or just keep it in the decimal?
I would round to the whole number.
Round to the whole number? Okay.
But I would say, I guess if you have a decimal, yeah, just round to like the standard 0.5 rule. Well, actually, I don't know.
Right.
That's kind of. I'll ask Kaylin because she actually works. Although I guess when you're working with like a map goal, does your machine just auto calculates the map, or do you have to manually calculate it? Okay. Well, his question was specifically, um, how is the rounding for the map? Like, do you know if the machine's round down by default, or is it just like if it's 0.5, it rounds up? Like, or how does that work? Yeah. Okay. Yeah. So she was saying is that well, so when she works, the machines kind of do it automatically, but she says generally, I mean, at least for this, like for your testing, when you do have to calculate a map, it will not be like 64.4 and then you're thinking or 64.5 and you're thinking should I round up? You'll get a very obvious number. And then what she was saying is that it's not really going to be that vague in real life because you're not, if someone's map goal is 65 plus, you're not going to keep them at 65. You're going to want them a little bit higher. This is a little bit of a buffer room. Um, so I'm not exactly sure on the rounding for that, but I do know that at least for the testing, it's not going to be like that. It's not going to be like you're not going to get one like your answer choices will be more on the obvious side. It's not going to be vague like that. You're not going to have to worry about the semantics of it. If I had to take a guess though, I'd probably round down overall. Because if someone's map goal is 65, you don't want to just have them at 64.5, you know?
Got it.
But
Thank
and
you.
yeah, in terms for testing, don't worry about it. Okay, let's see. Where was I? Yeah. So one of the things though to keep in mind is you're going to want a blood pressure cuff, manual blood pressure, at the bedside in order to do kind of confirmation. Because machines aren't always the most accurate. Maybe it's not fully calibrated right, or something else going on. Um, not might not be leveled, might not. So might be something else off with it. So you want to have a blood pressure, manual blood pressure that you can take, just to confirm it. But you don't want to have it on the same arm as the A line for reasons that are similar to the PICC line. Plus, you're constricting that A line, you might ruin the A line. So, yeah, so you're gonna want to make sure that if their A line is on their left radial, you're gonna do the blood pressure on their right side. And yeah, just to confirm it. So complications, these are things that basically are the same thing as with the PICC line. Clots, hematomas, infection, bleeding, all that stuff. Okay. Any questions on the A line? Okay, so then we'll move on to the Swan-Ganz, also known as the arterial line, pulmonary arterial line. So the purpose of this is to help to evaluate patients with various cardiac, circulatory disease, shock states. Nowadays, it's hospital dependent because I guess from looking it up, it's actually kind of outdated. It is not used as often anymore. Uh, they have less invasive ways of trying to figure stuff out. But for this class, this is what we're learning, so we'll just kind of deal with it. Although it's worth noting, I guess county hospitals still use PA lines. So some of the things that that this will provide for you is your CVP. So that's your central venous pressure. I like to think of it like a right arterial preload, meaning that this is the preload slash the pressure that's going into your right atrium. So pressure from your body that's coming up to the right side of the heart. So I like to think of it as this is like the amount of circulation or perfusion or blood flow that you have to play with, that your heart has to play with, available to play with. So this number is going to be between 2 to 8, difference depending on hospital. But for this, they want us to know 2 to 8. And so what does it mean to have a low CVP?
Hypovolemia,
Yeah.
possibly?
So
Is that what you're talking about?
no, that's correct. Yeah. So low is, you could say it's kind of like dry. So like, again, if I said that this is like the blood flow coming into the heart, this is what the heart has available to kind of play and manipulate with compensation and stuff. This is what you have available. So if you have a low number, that means you don't have enough fluid, enough blood, enough volume. So this would be hypovolemic. And what's your instinct say you should do when someone's hypovolemic? If they are lacking volume, what should you do?
IV fluids.
IV fluids, yeah. So this is IV, this is where an IV fluid bolus would be indicated. If someone's high, then the opposite's true, then they're wet. They're hypervolemic. In which case, what kind of comes to mind for the immediate plan of care?
Diuretics.
Diuretics, fluid restrictions, that kind of stuff. Okay, does that make sense? Get the general idea there.
Mm.
So this is what your heart has to play with. It's the preload going into the start of the heart. Next one is your pulmonary arterial pressure. This one, they don't want you to memorize. This isn't like a critical care a CRNA course. So they just want you to focus on some specific stuff here. But the pulmonary arterial pressure, this is the pressure that's going into the lungs. So I like to think of it as, oh yeah, that's what the pressure going into the lungs, the right ventricular afterload. So this is the pressure that your right ventricle has to fight to make it to the lungs. So if this value is elevated, that would be what you might have heard pulmonary hypertension, because there's so much pressure in the lungs. Your heart is now struggling to get blood to the lungs. which is why you see that correlation between pulmonary hypertension and right-sided heart failure, because now we're having difficulty on the right side of the heart getting blood flow across to the lungs. So that's why right-sided heart failure is called cor pulmonale, cor meaning heart in Latin, pulmonale meaning related to the lungs. Okay. The PAWP, this has a lot of names actually, the pulmonary arterial wedge pressure, also known as the left ventricular end diastolic pressure, also known as the pulmonary arterial occlusive pressure. This is going to be an estimation of the amount of pressure that it is going to be found in your left ventricle. So this is the pressure that's coming from the lungs and going into uh, your left ventricle. So this is the amount of pressure in your left ventricle after it makes its way through the lungs. The number that they'll want you to know is 4 to 12. And this pressure that's formed in your left ventricle then has to fight the systemic vascular resistance, which is essentially the pressure in um, the rest of your body that your heart has to fight against to get the blood out of the heart and flowing to the body to deliver the oxygenated blood. So the way to think about it, and you'll get more detail, week 3, we'll have more detail on all of the specific stuff here. But that's the main idea with that. So that's kind of what your blood pressure kind of shows is your top number, your systolic is the pressure upon contraction, while your diastolic is your pressure at rest. Your pressure at rest is kind of correlated with that systemic vascular resistance. So the reason why, kind of going back to previous semesters, is that someone in shock has a narrow pulse pressure, meaning that their systolic and their diastolic are close to each other, is because they're clamping down, meaning that their systemic vascular resistance is higher to try to accommodate for maybe a lack of volume. So the diastolic is higher because the pressure at rest is higher. Why? Because the body needs that higher pressure to get perfusion across. So that's where that relationship there lies. Okay. One of the things they can do is for the cardiac output. This is old school apparently. There is essentially a thermistor as part of the whole system that can detect changes in temperature. So the idea is that if you inject some cold fluid through the Swan scans, the temperature will change because body temperature and all that stuff. So the idea is that um, the better your cardiac output, the better your heart is at getting stuff across, the less time that cold fluid has to warm up to your body temperature before being measured. So if there's a higher change in temperature, that implies that it took longer to get to the thing reading it, as opposed to if the change in temperature is lower, it flew too fast for that change in temperature to happen. That's just don't really worry too much about the specifics. It's just knowledge that it exists. It's just a way to measure your cardiac output. Okay. So your Swan scans is inserted through a central vein. You have a balloon port. So I didn't explain is that pulmonary wedge pressure, that occlusive pressure, the way that it's measured. So your Swan scans will have a continuous monitoring of your CVP and your pulmonary arterial pressure it will not have a continuous measurement of your wedge pressure because in order to measure it needs to be wedged. So it has a balloon. Here's an example of a picture here. So the balloon is like right here. So the idea is that in order to properly measure or estimate the pressure that's going into your left ventricle, you need to put this balloon here. So the idea would be um, everything going in through this, following this line, is going to the lungs. So if you were to occlude all of this right here, it will be able to measure the pressure that's happening on the other side of the balloon, the pressure that's right here. So this is essentially the pressure the pressure of the blood flow after it has already fought the resistance from the lungs. It's very complicated and you don't need to know the specifics, but that is just to provide some context. That pulmonary wedge pressure is an estimate of the pressure remaining after your heart has fought the lungs to make it to be able to pump out. So it's an estimation of the pressure remaining, and that's an estimation of the pressure that's going to be coming back to your heart. So for that, you need the balloon. Okay. Alternatively, there's also a way to get the general estimate by looking at so there's a pulmonary arterial pressure, there's a diastolic and a systolic for that as well. Your diastolic pulmonary arterial pressure is equivalent to your PAWP. But again, you don't need to know that deep. So just really know the values and what this indicates, and the values and what this indicates, and that for the PAWP will be more detailed in the following weeks. Okay. So, but the idea is that there is a balloon port. This balloon port will have a special syringe, 3 ml syringe, but you cannot inflate the balloon more than 1.5. The reason that it's a 3 ml syringe is just due to the idea behind the size of the syringe and the how much pressure it's able to insert. So it's not about the quantity, it's about the pressure in terms of the size of the syringe. That balloon can only hold 1.5 mLs of air, but the reason why it's a 3 ml syringe is due to the buildup of it, giving it a specific pressure in order to make it safe. So you don't burst the balloon in there or have anything else happen. Okay, so the values that you want to know, I guess now it's ADN. ADN 240 is your cardiac output. You're going to want to know your cardiac output. Your cardiac output is going to be 4 to 8. And if you remember, your cardiac output is your stroke volume times your heart rate. 4 to 8 liters per minute. An acronym that's good to know for cardiac output is CRAP. It's your cardiac output is maintained by your contractibility of your heart, hence why you have medications that improve your contractibility like dobutamine, digoxin, based on your rate, which we can see because it's your heart rate, as well as your afterload, which is the pressure that your body has to, or that your heart has to fight to make it through to your body, and the preload, which is the pressure that your heart has available to work with in order to make that happen. You're going to want to know your CVP and your pulmonary wedge pressure. So these values are the ones you want to memorize for your testing. Here I have a list of typical medications that you will see. They will be put into more detail later on week 3, but for now, the idea is your norepinephrine is going to be primarily increasing your blood pressure. Your dopamine is going to be increasing your heart rate and blood pressure. Your epinephrine is going to be primarily increasing your heart rate, but it can increase your blood pressure at higher doses. But for now, just think of it like blood pressure, heart rate, This one does both. And then there's your vasopressin. Your vasopressin is your antidiuretic hormone. This one will not be titrated. This one will just be there, or it either will be there or won't be there. This one is based on how much of your norepinephrine's already being there. So I think it's whenever there's at least 10 mics of norepinephrine being there, the vasopressin gets put on. It's like a adjunct, like a mm, little supplementary vasopressor. And your default, like your go-to, is going to be your norepinephrine. That's your default. That's your go-to. That is your gold standard for vasopressors. Dopamine is like a we have nothing else to go off of. We're just gonna dopamine. It's like a harder to manage medication. It will definitely not be the first line. Epinephrine's the next one for heart rate specifically. So the main ones you'll see is norepi and vasopressin. And again, if you have more questions, ask Kaylin because she knows better. Your inotropic, so this is medications that help with other functions like heart rate and contractibility. Your dobutamine is going to increase your heart rate, increase your contractibility. Your digoxin is going to increase your contractility, but it's going to decrease your heart rate. Your milrinone is going to do the same things as your dobutamine, but it's also going to have a decreased effect on your blood pressure. And just get a general idea. You'll need to know them a bit more detailed for third week, okay? For now, it's just like a general idea, general guideline. And then here's a list of antiarrhythmics. So cardizem is used for like AFib with fast ventricular rate / rapid ventricular rate. Lidocaine is used to stabilize the irritability of the heart. Nitroglycerin, we know, um, helps with preload, afterload. Amiodarone specifically is an antiarrhythmic that can get used for someone that's having issues with funky heart rhythms. Just know they exist at this point. I'll try to get you guys out of here, so we'll just kind of focus, and I'm sure you guys are tired, so we'll just kind of talk about the next few. So nursing considerations for your ventilation, some of the things you want to think about. Obviously, someone's ventilated, you're focusing on respiratory, you're focusing on lung sounds, respiration rate, how much effort are they putting in, what's their O2 saturations. One of the things that gets measured as well is called an end-tidal CO2. So it's a little monitor that can uh, read how much carbon dioxide is being breathed out. There should be an expected amount. So if the ventilator is not properly set up, that number is going to be off. You don't need to know the specifics, you just need to know it exists. So this ventilator is going to be placed in just like your PICC line, just like your NG tube. You're going to have a centimeter reading of where it should be on your lip, like what number will be at your lip at, or what number your lip will be at. Yeah, so how long that tube is in, basically, gets that same idea out. You might have to rotate the positioning so it's not always on your left side, not always on your right side, so you don't get breakdown. It's every day. Um, you're gonna be focused on your vent settings, which will be more specific in a future week. Gonna be making sure that their airway is clear. They're gonna have restraints so that and sedation so that, like someone's unconscious, they wake up and then they have something down their throat. They're gonna freak the hell out and they're gonna try to pull it out. So that's why restraints are there. That's why they have a sedation goal. Your big focus is emergency equipment if they are unable to breathe. They make sure that there is an ambu bag for them for rescue, suction. so that you can suction them in case they're aspirating. Now, something you will need to know for the test is called the VAP bundle. So this is ventilator related guidelines for you to follow. So it's in order to prevent your pneumonia from happening. So some of the things that are included there. Let's see, I don't know why I closed the thing. Just copy paste that. Is that they're gonna have oral care. Every 2 hours, they should have oral care. Suctioning should be done as needed, and if it is as needed, it should be an every 2 hours as needed. Doesn't mean every 2 hours needs to be done. Um, but if you do it, the idea is you do it and then you don't do it again for 2 hours. Mhm. Okay. And then I want you to keep mind of the hourly rates because you might have a question where it's multiple choice and the right answer and suctioning is one of the part of the bundles, but they'll have an incorrect time frame for it. So they might one of the answers that are available might be suction every 8 hours, right? So you know that suctioning is correct, but 8 hours is not correct. So you don't pick that one. Okay. So keep note of that time frame. So oral care every 2 hours, suctioning is a Q2 PRN. So every 2 hours, but only as needed. DVT prevention protocols. So your heparin subcute, Lovenox subcute, head of the bed elevated, 30 plus degrees. You're gonna have prophylaxis for peptic ulcers because it's stress for stress ulcers. So omeprazole, famotidine, and then something called a sedation vacation, which is a interruption of your sedation to try to get them to start breathing on their own. Um, helps to prevent all this is to help prevent pneumonia. So it's your ventilator associated pneumonia bundle. Okay. Any questions on anything we discussed so far? Okay, so I'll give you this document, and then I have one for leadership and delegation. Um, I'm not going to go over it directly. It's very short, but this is something that you can kind of look at your own. The main idea is if you get asked as a multiple choice questions, which you could, it's like, what are the 5 rights of delegation? Making sure you have the right person, the right task, right circumstances, communication, supervision. Some of the things that you'll get questions on is like delegation to an LVN. So what are things that an LVN can do and cannot do? So you might have one where basically I'll just ask like what's appropriate. Can you delegate this task? Maybe not super directly. It might just be like an implied thing. So it might be like a question where it's like, which patient can you delegate to the LVN? And so you'll have to know, naturally have to know, it's like which patient can is not appropriate because maybe they have IB piggybacks or IB pushes that they have to get done. The patient for an LVN has to be stable. LVNs cannot do initial teaching, but they can reinforce. They cannot perform the initial assessment, and they can't do evaluations, but um, they can do kind of like they can do like checkups. So like you can have your LVN listen to the lung sounds. If that lung sounds abnormal to them, they will report back to you, and then you'll listen again to make the determination. So these are things that you should be aware of. Things to keep in mind is that if a patient, you can delegate anything that's direct patient care to meet your basic human needs, such as eating, drinking, positioning, ambulating, toileting. But for certain people, you might want to be a little bit careful. Something that maybe like a patient with a very, very high dysphagia, like risk of dysphagia, you might be want to be the one doing it because you have the license to treat whatever happens in case of a consequence. Maybe they do choke. Maybe they that because maybe they're a stroke patient. They do choke. It's not like CNA does it and then they have to then report to you to then come back to do something. It's just that you're already there for those high risk patients. Always focus on ABCs. Think about stable versus unstable. Think about that THINK acronym. The acute restlessness confusion could be hypoxia. It could be all of those other things that we talked about. Focus on a new admission because you don't know anything about them. You don't know if they could be stable because you haven't laid eyes on them. All that kind of stuff transferring. Okay. Um, so I'll give you guys that as well. And then after that, we're done. Let me know if there are any questions on anything we discussed. Next week, I think. Oh, by next week, I mean, let me check when you guys' test is because I know I said I was gonna do the rhythms, but it might take a little bit. I might take too much time. When is your test? Because I think usually it's fine, but it looks like you guys are actually doing your week 1 and 2 on the same exam. Wednesday. Okay. So this Wednesday, you guys will have a test. Today is Friday. Are you guys free on Monday or no?
Everyone's in clinical.
Clinical. Okay, sheet. Okay, Tuesday. Tuesday. I think Tuesday should work. I could do Tuesday. Either that or I do tomorrow or Sunday.
During the day or
Uh,
because some of us have PEDS clinicals
ew,
next week.
okay.
PEDS clinical start.
Well, I thought that was Thursday for you guys. It's on Tuesdays.
Huh?
I said I thought the Pete's was on
No, some of
Thursdays.
us different days.
Oh,
No, like
okay.
some of us have I have Tuesday and Thursday for clinicals. I mean for PEDS clinical.
Oh, that's horrible. Okay. Yeah, that sucks. I'm sorry.
Yeah. But that's not everybody. That's just my,
Yeah,
our
gotcha. Okay. Sunday is fine though, or t yeah, Sunday's fine.
time.
Yeah,
Yeah.
yeah, we could do it at the same time, 1 p.m. and we'll go
Oh,
over the
cool.
arrhythmias and stuff like that. All right. But I'll give you guys the stuff so you can look at it on your own, and then we'll have like a session just to be like, if you guys have any other questions or you want me to specifically go in detail, we can do that. So let me stop the recording for now.